Good evening, all. Welcome to IDA Ernad branch. Today, our topic is oral cancer, early detection, identification, and referral. It is a topic which might sound simple, but the importance of it cannot be overstated. Let me share few words about our speaker. We are so grateful and lucky to have Roshith Valiyamannil as our speaker today. Dr. Roshith is a specialist oral surgeon and implantologist who has 23 years of experience in dentistry. Hailing from Manjeri, he is a proud son of our branch. He has done in his BDS from YDC and MDS oral and maxillofacial surgery from AB Shetty Dental College. He moved to UK in 2005 after working for few years in Kerala and Dubai. He has done various master's programs in implants, intravenous sedation from the prestigious Royal College of Surgeons of England, London. He works exclusively as an oral surgeon and implantologist in UK. He is an international speaker and also helps dentists to aspire their dreams to work in UK. He is the founder president of Association of Indian Dentists in UK and has a reputation of being very approachable and humble. Ladies and gentlemen, please welcome Dr. Roshith to take over the presentation. Thank you.
Hello, everybody. Good evening. I think I can. I'm audible to all of you.
Yes,
First of
perfect.
all, yeah, okay. First of all, let me thank Dr. Mohsin for asking me to do this webinar. My friend Mohsin, and then Dr. Shyam for arranging this wonderful webinar. It's not very easy to arrange all these things. It's so technical, and we being a dentist, we are not very tech savvy. And thank you, Sam, for arranging this wonderful webinar. Thank you again for all of you who has taken your time, your busy time to come and attend this seminar and attend this boring topic, I would say. But I'll try to make it a bit less boring. That's for my, I've done this presentation before, so I try to make it a bit more, interactive rather than a bit boring one. Now, I have in this participants, I have a lot of my friends from UK, people all around the world now actually have asked me to give the links. I've provided the link. I hope everybody is inside. Unfortunately, the Facebook link has not been working, so people who have come in, first 100 people who have come in will be only getting the access to this webinar. But we will be recording it and streaming it through the YouTube in few hours time. Let me welcome all my friends, my batchmates. There are a lot of my batchmates actually listening to this. Thank you all of you for coming down, and my juniors from Yanapaya, and my friends in India, in the UK, various parts of India actually, the friends from Chennai, Mumbai, and Pune, and Bangalore. Also, let me welcome all the friends who's very close friends, my colleagues from the UK as well. There are people who are listening from Abu Dhabi, Dubai, etc. as well. So it's a international kind of a webinar rather than initially that we aspire to become only an Ernad branch idea webinar. But thanks for all of you for coming and joining. Let us start. And also we have a very a senior member amongst us, Dr. Joy Thomas. I don't know whether Dr. Joy Thomas remember me, but I had the privilege and honor to work with Dr. Joy Thomas in my early years of experience. I've learned a lot from this, extremely talented and very, very respected member of our branch and who is well known all around Kerala. Very, very busy dentist, Dr. Joy Thomas. Thank you, sir, for coming and joining us as well. Okay, I think we probably start the presentation now. Let
Yes,
me come. Yeah. Right. Oral cancer early detection, identification, and referral is the topic today. So as Syam has already introduced me, I don't have to tell more about myself. Thank you, Sam, for doing the wonderful job. Always everybody likes to hear good things about themselves, so thank you for that. So what we're going to learn today, basically just early detection of oral cancer, how we identify it clinically and radiographically, and how we refer it very quickly and promptly. This is what we could just a quick, there's no theoretical things what we're going to learn about it, more clinically and radiographically, how we detect it, identify it early, and the importance of identifying it early, and how we refer it. That's all about we are talking about. What is the prediction of the oral cancer among the world? So if you could see the map here, you can see the highlighted area, the red areas are in India, Sri Lanka, Pakistan, and Bangladesh, mostly. In our subcontinent, it is one of the most common cancer compared to the whole world, you can see how prevalent that is in our part of the world. So I just wanted to highlight this situation, this particular condition, how prevalent it is actually. Oral cancer, imagine, or the whole of oral cancer is more prevalent in our parts of the world. So what the statistics say is, oral cancer normally is the 11th most cancer in the world. But in India, oral cancer is the second most common cancer, according to the latest studies in 2019, which I've just recently read about. It is the second most cancer in India, and it accounts for more than 30% of all the cancers in the country. So imagine how common it is. India alone accounts for the 1/5 of oral cancer cases around the world, and it actually accounts for 1/4 of all the oral cancer deaths around the world. And it ranks, among the men, it is the number 1 cancer in India, and number 2 cancer among the women after breast cancer. So you can imagine the magnitude of how common oral cancer is in India. Incidence in India is actually 15 people out of 1,000 people has got oral cancer. How common it is. People like Dr. Joy Thomas and people who are very busy will be seeing 1,000 people in a month or 2. So you will be seeing, or screening, without screening, 15 people in 1 or 2 months' time. So this is staggering. And mostly seen above the age of 65, and in male to female ratio, it's 2:1. Now, the last point is very important, actually. Early diagnosis and treatment plan reduces the mortality rate, that is the death rate, up to 70%. So 70% death rate can be reduced by early diagnosis and treatment. And as you all know, how important the role of a dentist to diagnose it in the early stage. We are the only people who will be looking into somebody's mouth. And also, as you all know, the oral cancer in the early stages are very painless. So the patient tends to ignore it and just leave it until it comes to a stage where it can be really difficult to treat. So we are one of the most important people to diagnose it and change a very important change in somebody's life, to save their life. And it will be important for the whole family. So how noble, profession we are, we are in that, in a stage where we can identify and save somebody's life, not one, not two, many. So this is very important. So we need to know about this. So I was just looking at how Kerala is. So which state in India has the highest cancer rate? Can you see that? That's in the Times of India in 2018, published. Kerala is the highest cancer rate in India. That was staggering as well. So even though it is not oral cancer as such, but the whole of cancer in all over India is common in Kerala. So of course, out of that, second most common cancer out of the whole cancer in India, second most common cancer is oral cancer. So we are a very, very, very important people. So as you can see, only two red areas in the whole of India. That is Kerala, and they are in Mizoram. So how important that is actually is the first thing. Now, before going into the very, I don't want to go into the theoretical part of it. So I thought I will tell you a few stories of 3 patients who I have come across in my own clinical experience. So these 3 patients, which I'm going to tell you in a story wise, so that it will stick into your head rather than me just telling something, a lot of things about oral cancer. So these 3 cases has come through my own experience, and I thought I will share that 3 cases rather than theoretically boring you. So this first patient was right. So I was initially, when I was working in the UK, I was working in a place called Leeds. In 2016, I moved to Leeds. Is actually north part of England. I moved in 2016. I moved to southeast part of England called Kent, where I started to work in a place called Ashford. One of my colleagues actually works with me in Ashford. Is in the discussion today. Hi, Samir. Hope you're there. Now. In 2016, when I started working in Ashford, my first day in Ashford, I saw a lady for a checkup. This lady, around about 60-year-old lady, who came with no complaints, nothing. And I look at inside the mouth, her left side, the lateral aspect of the tongue, had a huge, very suspicious, angry-looking lesion, which I told the patient that I will refer you to the hospital. She said, "Please, doctor, don't refer me, please, because I've been to the hospital 2 times in the last 10 years, and they cut my tongue, and it was so difficult, so painful to eat and talk, and please don't do it." And both the times the biopsy have come up as negative. So I don't think it is anything sinister, but I would not go for the hospital appointment. I paused a bit. Then I told her, "See, Mrs. X, I think it is a bit suspicious, in my opinion. I've seen a few of them, worked in the hospitals, and I think it looks a bit suspicious. Even if it is not there, it will be only good thing to check it. And as a dentist, my duty of care is to send you to the hospital. It's up to you to whether you go for the appointment or not. But I would ask you, I would advise you to go and for the referral appointment and see what happens." I sent the referral through. So referral, in the UK, we have a set protocol that we can refer the patient in 3 different. It is done online. It's on a software called Rego, and it's in 3 set of protocols. One is urgent, which the hospital has the liability to see this patient within 2 weeks frame. This patient has to be seen in 2 weeks time, and I've referred the patient in 2 weeks time. Urgent one. The patient was seen for the biopsy, and you know what? It was a cancer. The patient had an hemiglossectomy. There was no nodes, but still they have done a nodes clearance, and they didn't have to do anything but hemiglossectomy. But patient still can talk, and the patient came back with a bouquet of flowers. As you all know, these sort of small gestures, is so important in our career, and it made me feel very proud and very happy, so that I can save somebody's life. So these sort of small things will make the profession worthwhile. Okay, the learning point. I always say there's a learning point from every case. So the learning point from this particular case, there are 3 learning points, to be honest. One, first and foremost important thing is, even if the previous biopsy have been come back as negative, it can still turn into malignant anytime. So just because the previous diagnosis was benign, it doesn't have to be benign all the time. So that's the first thing to understand. Second thing, patient will say, oh, sorry, I don't want to go. I have pain. I had pain last time. I don't want it to go. But as a dentist, it's your duty of care to send the patient. Whether the patient attends the appointment or not is not your concern, but your duty of care is to refer the patient. So you've done your job, then it's up to the patient whether she goes or not. Third valid important point is actually when it comes to a litigation, you have done, because it's all online, it's done online, so the referral that you've sent through is there on the date that you've sent the referral. So you will not be, because in case if the patient didn't go through and she had a massive malignancy and she had to have a massive operation disfiguring her face or anything, and if she goes for a complaint, that you can there's no backup for yourself if you're not referred the patient, and if you've listened to the patient say, all right, okay, she's already had it 2 times and she don't want her to go ahead with this, so I will not refer her. If you had done that, in case if it comes back to you, you have no stand, and you can't say that you've done it according to the patient's wish. But you always should, as a dentist, your duty of care, first thing is to send patient. Otherwise, you will be in trouble, because even if there is no way you can tell that, oh, just because I didn't send it because of the patient said to me. No, it's not the way to do it. You have to send it. So there are 3 very good important points to learn about this patient. Now, next patient, this is a very good one. This is an hospital case, okay? Now, I was working in a hospital called Bradford Royal Infirmary in Bradford in 2006. I think my colleague who worked along with me, my friend, very good friend of mine, Viju, will be there in this discussion. Hi, Viju. Hope you're there. Now, we were seeing this patient. This gentleman was actually admitted in the hospital with a major operation. And he was in the ward, and we were looking through his story. So the story goes like this. This patient had an extraction of lower right 6. Lower right 6, which was a bit mobile and taken out. And, nothing uneventful happened during the operation, during the extraction. Patient went back. Patient came back after 2 weeks' time, saying it is still not healed and it's still bleeding. The dentist started looking, and oh yeah, it still got some infection. We'll give you a course of antibiotic and plugged in some alveogel into the socket area there, which was not there. There's no dry socket, but still they put some, kind of an alveogel there. Sent this gentleman home with course of antibiotics. This patient came back 4 weeks later, saying exactly the same thing. So this dentist took an X-ray, a periapical X-ray and shows like this. And they said, oh yeah, there's an infection still not gone. I'll give you another course of antibiotic. And I think the lower right 7 and this lower right 5 is also a bit mobile. I think we may have to take them out as well because they are all periodontally involved. So it looks like there's a bit of a gum disease in the place as well. So this patient went back again after a month. He still have the same problem. It is still bleeding and it's still not healed very well. So when he came back to see this particular dentist who used to see this gentleman was on an annual leave, and then another colleague of him seen, and he has seen the whole notes, and he thought something's not right. So I'll just take an orthopantom OPG. So he took an OPG, and this is how it looked like. Hope you all can see the slides very well. So the OPG shows like this, a huge radiolucent area in the lower right mandible region, extending from the lower right 7 till 5. And this dentist immediately referred this patient to hospital. They biopsied it, and it came back as squamous cell carcinoma of that area. And he had an hemimandibulectomy, nodes removed, and iliac breast, was placed to reconstruct the mandible. This patient actually went as a case against this gentleman, and the first dentist. He was in the GDC, and that's the General Dental Council in the UK, and he was erased from the register. That means he cannot work as a dentist anymore. So it is a very alarming situation, and there are thousands and millions of cases that's happened in the GDC. So we have a strict protocol, which I will come to the in the examination part, which I will tell you. So every 6 months we have to see a patient. It doesn't have to be for any particular case. So 6 months regular checkup. In the 6 months regular checkup, we have to have a complete oral screening, and it has to be the whole screening. I'll tell you when I'll come to the examination part of it. So that has to be there. That has to be performed. And it has to be done. It has to be put in your clinical notes, so that if anything goes back, you've already done it. There is a in your clinical notes, it's already written there. So every patient who comes for the checkup has to go through the clinical, the oral cancer screening, mandatory. And this particular presentation is done for a UK presentation because we have to attend at least 1 hour of CPD. We call it CPD, you call it CTE in India. The CPD hour, 1 hour of CPD has to be done. It's a mandatory thing once in 2 years' time. So this is as important as anything. Even though in the UK, the statistics, oral cancer is the 4th common cancer in the UK, whereas ours is the 2nd. So we are much more, seeing more patients, and we have to have a particular, at least yourself who are listening to this should take this as a very important thing. And you need to screen every patient who doesn't matter what they come for, doesn't matter how busy you are, it doesn't matter at all. You have to screen every single patient comes through the door to see. Okay. So I will tell the learning point of the scenario 2 and 3 at the same time. Now, scenario 3 is again a GDC complaint case. Now, this person who was dealing from the GDC, that's a General Dental Council, in the GDC panel against this dentist, was very close to me. So I know this case very well. This particular case had loose tooth. Now, this lady is 65-year-old lady, had no teeth on the lower left 7, lower left 6, and lower left 8 is missing. Same on the other side, but the lower left 5 was a bit mobile, just a bit mobile, no pain, nothing. So this patient came to her own dentist, told her about the loose tooth, had a look, take some PA, X-rays, nothing significant. Did some deep cleaning, sent the patient off. I think she gave some antibiotic as well, and sent the patient home. This patient came back for the next set of appointment, which is this next set of checkup, which is 6 months later. She came back. The tooth is much more loose at this time, more than grade 3 mobility. It's very, very loose. This patient, this dentist said, right, okay, it's better to take it out. This patient was not very keen on extraction of the tooth. So she said, I will, the dentist said, okay, I'll send you to the hygienist to see if she can do a deep cleaning, or I can send you to the periodontist to see if they can, tighten this tooth up a bit. She went, did all that. Still, the tooth is loose. She came back after 4 weeks of seeing the hygienist, and she said, can I see another dentist? So she saw another dentist. They took an OPG, and there was a massive, massive radiolucent area extending from the ramus of the mandible all the way to the lower left 5. Again, this patient was referred to the hospital. They did a hemimandibulectomy, did a major case. They had nodes removed. Everything was done. Unfortunately, this patient died in 4 months' time. Her daughter went a case against this particular dentist and the hygienist, and the hygienist and the dentist both were erased from the register. They both can't no longer work as a dentist in this country. So this is how serious this matter in this country is actually. So it is very important. Very strict protocols are in place. So that's the reason. I think it is always better to have a screening protocol for all your patients, at least to start with. There's one more scenario actually that just came into my mind. Actually, I just thought I'll tell you that as well, and then I'll tell you about the learning point. This I was working in hospital in Coventry University Hospital of Coventry in Warwickshire in 2007. I was on call. That means we have to be on the weekend there. So if you see any patients, we have to treat, refer, or do something about this patient. So it was Sunday evening, around about 3 o'clock. I was a bit dozing off. There was no patients. I was dozing off, and then I got a call from the A&E, that is accident and emergency, and they said, "Oh, we got a patient, 8-year-old girl with bleeding gums." I was thinking, "Hey, bleeding gums with an emergency?" I thought, oh, goodness sake. Anyway, I asked them to take an OPG, and I'll come down. And I look, there was nothing wrong with that lady. The girl. An 8-year-old girl, very sweet Asian girl, no problem. And I said, I looked at the OPG, there's nothing wrong in the OPG. And I said, there's nothing wrong. And the father was telling me, actually, you know what, when it bleeds, it bleeds. It bleeds like hell, with buckets of blood. And I said, I can't see anything. But since you said that, I will call you back, because it's on Sunday. I don't have the consultants and everything. And it is not bleeding at the moment. I'll call you back tomorrow and do some bloods and come back. Sorry, I didn't do the blood. Sorry. So this patient came back to see the consultant very next morning. The consultant saw the patient, and she asked for some blood reports, blood check, and the bloods came back. Blood report came back, and it was actually blood cancer. Yeah, leukemia. So I was called to my consultant called me and I said, it is a learning point for you. So I thought it was a big blunder from my side. I should have checked the bloods on the first day, and the patient could have actually bled to death on that night, and I would not have, forgiven myself. So it is something that you can learn from. So the learning point for all these three cases, actually, we will all have one irritating patient in our list, one or even more. So when you see this patient's name on the list, and first thing you come in the morning and oh God, not that patient again. You all will have that. Most of the time we are right. As a dentist, we are right. We know what we're doing. But sometimes the patient is right as well. So when you have a constant kind of a patient coming back with the same sort of problem, there should be something going underlying there. So you can go for either more investigations or ask your colleague or friends or somebody if you're not, happy about it. If you are not very, sure about it. But always one motto in this thing is actually, if you are in doubt, just refer. If you are in doubt, just refer. Nobody will tell you off for referring a patient which don't turn out to be a cancer. It doesn't matter. You just refer whatsoever. So I think it is one of the learning points from all these cases. Don't take lightly. Any cases, don't take lightly, and don't prejudice. Just don't think, oh, that patient is always pain, so she or he is always complaining, things like that. That things that it is there. Most of the time you're right, as I said, but sometimes they're right as well. So just be wary about this, and then keep in your mind. So this is all a bit of a theory part of it. Tobacco is the main cause of cancer. We all know that. Tobacco in various kinds of use, either smoking, Ghutk, chewing by betel nut, Arecanut. Alcohol consumption is considered as one of the most common after the tobacco. Poor nutrition, age over 40, and genetically also they have said it's high risk. Genetic risk is there. On top of this, environmental factors like tobacco, alcohol, poor nutrition can make it more vigorous and make it come. Chronic trauma. Now this is very important. In chronic trauma, sharp tooth, fractured fillings, ill-fitting dentures, broken posts, and other chronic irritation like chemical irritations like amalgam fillings, the mercury within the amalgam. I've seen a lot of patients in here with Arecanut reactions to amalgam fillings on the buccal aspect of the cheek, in the buccal mucosa. You can see, you can clearly see where the buccal amalgam filling is, touching the buccal mucosa. There, you get a white, irritating area there. Some people also put this betel cute with some lime placed in the buccal sulcus area. That can lead to oral submucous fibrosis and, of course, into the dental oral cancer. Some patients with human papillomavirus infection has a very, very, very high risk of getting cancer. That has been proved, and there are lots of papers regarding that one. Very, very interesting ones as well. Ultraviolet light, very, very, very less in India, but it can cause lip cancer as well. So what are the most common sites of oral cancer? This is very important. So most common site, it is varied actually. It depends on country to country. In the UK, it is the tongue, whereas in India it is the buccal mucosa. Due to various reasons. One, obviously, of the betel, which I said, the betel cute placed in the buccal sulcus. Could be that. So buccal mucosa has to be definitely checked. All the patients, and also the tongue is one of the most important area, and 2/3 of the on the lateral aspect of both sides of the tongue is very, very, very important. These are the two most common sites in India. Floor of the mouth, lips is palate, soft palate, gingiva and teeth, oropharyngeal area, mandible, and maxilla. Okay, these are the most common sites. So now, how coming to the examination? So how we detect it? So every patient comes through the door. You can see there's any facial asymmetry or any difference in the changing in the skin, any redness, any puckering, any swelling. You can see it straight away. So that is a mode of examination straight away. Then when the patient, if the patient say, if there is any lower lip or the chin area, if there is any numbness, that is a very, very interesting and a very important clinical sign that will tell you about something is going on underlying in the mandible. Because any infection, any carcinogenic activity will suppress the nerve there, and the nerve will destroy itself, and then there will be no sensation of the lower lip and the chin in that area. So that is a very important feature, they say. If it is that, you need to take an X-ray or PG if possible to see if there is any underlying cause. All these lymph nodes we need to check, like preauricular, postauricular, submandibular, anterior cervical, posterior cervical nodes has to be checked. And then obviously we check the muscles of mastication, salivary glands, and TM joint. So how do you check? Now, extraordinarily, you have a few ways of checking the preauricular lymph nodes. You can see that very clearly there. This is all diagrammatic, so you can not miss it. So just go behind the patient, check, just check whether there's any trouble on the preauricular region. On the postauricular region, just behind, you can feel there is any lump there. Okay, so this is what you're looking for, is any lump. That is the nodes we're looking for. Just check the submental nodes, and the very important one is the submandibular nodes. Yeah, and you can even, you might have already learned in your BDS, we have something called bimanual palpation, where you place the 3 fingers underneath the mandible there, and with your finger inside the mouth, you can just, pass your finger inside the mouth, on the floor of the mouth. You can feel any lumps, or sometimes you can even feel the submandibular gland duct, duct calculus. You can even feel. I've found a few of them like that. So, these are the things you can find out, and obviously any lump there. They also say there is a lateral, you can see the TMJ palpation on the lateral and the posterior, where you place the index finger, the small finger into the patient's ears and ask the patient to open and close the mouth, and wiggle the mandible both sides. If there's any increased or decreased mobility, you can feel it on there. Obviously, the posterior cervical lymph nodes can be checked anteriorly and the posterior of the sternocleidomastoid muscle there. So you can see that muscle's been palpated there. So these are the other 2 important ones as well. Subclavicular lymph nodes, which is also common. Very rare to get a lymph node spread from the mandibular region, but it is there. There are lots of cases has been reported with subclavicular lymph nodes. Only subclavicular lymph node was infected, so was spread was there. Occipital lymph nodes, and just behind the sternocleidomastoid muscle and the occipital area. So in intro, this is the important thing. So coming into the inside to the mouth. Now this is the most important part. Now you look for or ask for the patient for any bleeding. Obviously, if there is any bleeding, the patient will tell you. So as we discussed in the first case, in the case scenario, we have a case which was with bleeding. So bleeding comes, we never take it lightly. Swelling, painless ulcers, and loose teeth. We've already gone through this, so you have an idea what you have to look into, and then whether it is important to take into consideration or not. Then you have to check, obviously, the gingiva supporting connective tissues, ligaments, and bone. then you have to also check the hard and soft palate, very important there. Soft tissue lining around the mouth and the throat, the oropharyngeal region, and the tongue and the lips. Okay, now how you do it. This is the diagrammatic and the sequence of intraoral examination. This is the diagrammatic way of doing it. So ask the patient to obviously open the mouth, look inside the mouth on the palatal area, so on the hard palate region. Then you can use a spatula or just simply use the back of your own mouth mirror. Just depress the tongue with the mouth mirror and ask the patient to say ha. When the patient say ha, the soft palate moves up, and then you can see the soft palate and the oropharyngeal area there. Then you can ask the patient to stick the tongue onto the roof of the mouth, like that, and then you can see the floor of the mouth. Then you can ask, you don't have to pull the tongue, which sometimes some patients might feel a bit annoying. So we can just ask the patient to just stick the tongue out first, and onto one side, and onto the other side. So just see the lateral aspect of the tongue on both sides. Then you can retract the top lip, upper lip, and see the vestibular area there for the gingiva and the mucosa there. And then, of course, while you're doing it, you can also feel the lip with your finger, see if there is any swelling, any puckering, anything that is not normal. You can feel it. That's kind of a palpation as well. So then you have to see the buccal mucosa on either side, which just elevate, retract it, and just have a look. And same thing on the lower lip, just retract the lower lip and see the vestibule there and the mucosa, and obviously texture of the lips. This is the sequence of doing it. So what are the precancerous lesions? What it is defined as a morphologically altered tissue in which cancer is most likely to develop than its original counterpart. So I don't want you to mug all these definitions. All I want you to know is it can take up to 15 years without changing its character. So there is 15 years, sometimes it might go unnoticed. So this is very important as well when we look into this. So very important for us, the most important people are us to detect it early, and so that we can save somebody's life. There are, the lesions are leukoplakia, the precancerous lesions are leukoplakia, erythroplakia, and palatal changes associated due to reverse smoking. You might have seen some patients with palate with red spots, or lots of red spot. It's actually it doesn't have to be reverse smoking. Sometimes even smoking directly into that soft palate area or hard palate area can cause that. Actually, I've seen it even without reverse smoking. So some cues for you guys. Because of this, I do this into the live audience. I normally ask questions, but now you can think yourself what it could be. Given you a clue, it is a precancerous lesion. So what it could be on the right hand side, and what it could be on the left hand side. Think. Right? Shall I tell you the answer? It is leukoplakia on the right hand side and erythroplakia on the left hand side. You can see that the difference. Okay, leukoplakia is white in color and erythroplakia is more red in color. Both are precancerous lesions. It can change into if it is not treated. So these are cases which you need to refer promptly. So what is this? This is a very interesting one, actually, to be honest. What it could be? Is it a cancer, or is it something else? Do I have to refer the patient? Well done from SN. Unfortunately, it is not SEC. It is not SEC. This is Sonia, very good. But unfortunately, this is a very important one, actually. It's a traumatic ulcer. It is very, very interesting slide. I always put it. It is turned out to be traumatic ulcer. Now, the reason why I put these lesions is for a very important. Yeah, well done. Aurora Dental. No, basically, traumatic ulcer is due to, which we've already told, sharp tooth, amalgam, broken amalgam, or any other fillings, sharp pores, ill-fitting dentures, things like that. So the protocol is to remove the cause of the sharpness. If you find a patient like this and look for any cause of the problem like this, so you then have to reduce it or remove it. So if it's a sharp tooth, smoothen it. If it's a broken filling, replace it. If it's some post, remove it or smoothen it, whatever. Then you have, the protocol is you have to see this patient in 2 weeks time. You have to recall this patient specifically in 2 weeks time. In India, if the patients are not very, understanding, or if they don't come back, you have to make them understand how important this is. Sometimes you have to be plain and blunt to the patient, say it can be something very dangerous. So you have to come back in 2 weeks time to see me, to see whether it has changed. So if it is resolved, the patient has to be, the protocol is to be seen again in 6 months time, just to see whether the lesion is resolved, is coming back or not. The patient has to be informed that if in case it changes its color, or if it's it doesn't particularly have to be painful. This one, again, another important thing in this one, this will be painful. This tongue will be really painful. And if the pain subsided, but the ulcer is not gone, the patient has to come back. Tell the patient very importantly that it doesn't have to be pain. If the lesion is come back, you have to come back. And after 2 weeks time, when you're checking it, if it is not resolved, you have to refer this patient. So this is the protocol. So refer, remove the cause of the problem, see the patient in 2 weeks time. If it is resolved, brilliant. You see the patient back in 6 months. If the ulcer is not resolved, you need to refer the patient urgently. So this is the protocol. So that's why I wanted to put you this slide. What is this? Send me some messages so I can see. I didn't realize you can message it. Come on, guys, come on. Can't do it. Brilliant. Lichen planus. Jaya. Oh, Jaya. Hello. Are you there? Oh, thank you. Very close friend of mine. We worked together in Bradford Royal Infirmary. Hi, Jaya. That is actually well spotted. Actually, Nishu and Jaya, you guys are absolutely spot on. It is lichen planus. It is 3 different presentations of our lichen planus actually. So yes, well done, Aurora. So yeah, it's 3 different. Sumod, hi, my batchmate Sumod is there. Yeah, this is 3 different types of presentation, which is the common one is the middle one. You all can see that it's a very, anybody can tell it is actually lichen planus. But the other 2 ones are a bit, tricky ones actually. The one with the full generalized lesions. You can see what's the difference actually. You can see the attached gingiva is actually red, but all the other areas are considerably normal. And the other one is on the right hand side is an ulcerative lesion with a hi Sonia. Second one is discomative. You're right, actually discomative gingivitis actually presents exactly like this. This is the reason why I wanted to put this one. Discomative gingiva will have more there will be more swelling and very red, and the interdental gingiva will be more swelled up. You can see that. Whereas this one, the interdental gingiva is more or less normal, and it is not bleeding like mad. Whereas in the discomative gingivitis, yes, you're absolutely spot on there. Actually, that's the only reason why I wanted to put this. So it could be oral lichen planus, one of the lesion, one of the reason I wanted to put these 3 different presentations of oral lichen planus. And the right side one with this ulcer there is also on the attached gingiva. You can see that it's very, very painful as well. So it's oral lichen planus. Precancerous conditions, obviously, it is a generalized state where it's a significant risk of cancer. Submucous fibrosis is very common in India because of the betel nut chewing and others. Erosive lichen planus and oral syphilis are the most common precancerous conditions. So I thought I will just put some cues again. Come on. What is this? Let me see some messages. Look at that state of that tongue there. Very, very angry looking tongue. I would draw for this patient straight away. This is Shaukat Ali, OSMF, SEC, Aurora. Anyone? Come on. I thought you guys are very SEC, Aurora. Vipa. Hi, Vipa. You're there. Okay. Jaya, it is candidiasis looking. That's the reason I put it in here. Actually, it is a very, very good one. Yeah. Again, it looks very much like an candidiasis. Yes, actually, it does look like that. But the turned out to be an erosive lichen planus. Actually, these both are histologically proven erosive lichen planus ones. These both of them looks very much like candidiasis. And yeah, you're absolutely spot on there. And also looks like very, very, very much squamous cell carcinoma. To be honest, when I saw this patient, I saw this particular one, I was concerned. I was confused between was it NCC or erosive candidiasis or erosive lichen planus. I was confused. So I thought I will make you confused as well. So yeah, this is the different kind of a different clinical presentation. Which, again, the motto is, if you are in doubt, just refer. Nobody's going to tell you off. So just do that. What is that? Everybody's scared now. Come on. This is very easy. No? Nobody want to? Nobody want to comment? Oh, yes. Q6 plus. SEC. Yep. I think you guys are absolutely spot on. I need more clues. No, yeah, come on. Sonia, SEC. Hi, Sonia. Ishar, hi, Joe. Yeah. Okay. Syphilis. Yes, actually, it looks more of syphilis. Actually, it is very confusing with the syphilis. It's actually calculation. I don't know. No, it doesn't look like calculation. It will be more on the floor of the mouth rather than on the structure of the tongue. This is on the ventral aspect of the tongue, actually. So, Shaukat Ali, feel like in front of an examiner. I am not that bad, man. Come on, Shaukat. I am friendly. So that's actually our old main famous squamous cell carcinoma. This is very, very important, very common of all the cancers in the mouth. So verrucous carcinoma could be. Verrucous carcinomas are actually extruding type of. This is ulcerative. That's how you differentiate between verrucous carcinoma and squamous cell carcinoma. Squamous cell carcinoma, most of the time it will be more ulcerative lesions. Verrucous carcinoma have an like a verrucous growth outside from the surface, so that you can see, and it bleeds like mad. So this is how you actually, and it is like, you know, nodules kind of things which comes out, and you can see from the surface there's an elevation from the surface, whereas this one, the squamous cell carcinoma, there's a depression. So you can see that, you clearly see that there's a more depression there, and ulcerative lesion rather than a growth outside. And verrucous carcinoma is not as common as squamous cell carcinoma inside the mouth, which is also important. So how do you diagnose radiographic? How do you see what's the difference between any other lesions in the mouth? Just wanted to show you the difference radiographically. On the top one, you can see there is it's a dentigerous cyst. Okay, so you can see the demarcation, clear demarcation of the lesion, with an unerupted third molar there, which could be the reason of the dentigerous cyst. So that is very, very typical in that. You can see there is no resorption of the roots. Whereas in the second one and the down, you can see that there is not only resorption of the roots, the lining is not well demarcated, it is diffuse, the edges, and also you can see that that third molar has been pushed up into the ramus of the mandible. So there will be all sort of characters like this. There will be displacement of the teeth. There will be resorption of the teeth. Yes, second one is tumor. Yes. Second one is, that's the difference between how do you differentiate radiographically between a cyst and a tumor. So the tumor will have a resorption of the roots, displacement of the teeth. Sometimes it doesn't have to be always all the time. There will be, the most important thing is the diffuse borders. There will be no clear demarcation of the lesion. That is very important one. Okay, and you can see the other one is got a clear demarcation of the borders, whereas this one, you don't have a clear demarcation. It just goes diffusely. It just goes like that. Hope you understand. Yeah. Now, other things which you need to be very careful about is metastatic tumors. This is very interesting ones actually. The first one on the with the red arrows there are a metastatic tumor from the lungs. Okay, so this might present to you as there's no significant problems from the teeth. So there's a clear radio lucent area in the mandible on the left hand side. You don't know what it is. Again, you refer. You are not sure. You refer. And that's a metastatic tumor from the lungs. Just wanted to tell you this also can happen. The second one on the left hand side with a white arrow is actually a metastatic tumor from the stomach. so that's the one. And the one with a round marcation on the right hand side, on the left side of the mandible, ramus of the mandible, is a metastatic tumor from the stomach. It was from the stomach. Sorry, that was from the intestine. Sorry, from the intestine. The other one was the stomach. This was from the intestine. So you can see, from where all it can actually metastasis into the mandible. The last one is the most interesting one. Do you know where it is? Can anybody guess where that's from? It is a metastatic tumor from down somewhere. Well, tell me about it. So it is actually, can you guess, anybody? It is, no? It's a prostate cancer. Yeah, sorry, lung is actually, we have already discussed. Yes, it's prostate. Well done, Amit. Hi, Amit, you're there. Okay. Hi, my colleague. Hi. Okay, so yeah, so this is prostate cancer actually. So can you imagine where all the cancers can spread into mandible or maxilla? So this, I told you there are 3 ways of doing it: urgent one, prompt ones, and non-urgent or routine ones. Okay, the urgent one has to be seen in the hospital in 2 weeks' time. So you have to do that. So urgent referrals, what do you refer the patient as urgent? So what are the ones which you refer urgently? So any unexplained, to the very, very important one, this slide is actually, so just be very careful with this. Any unexplained tooth mobility which persists more than 3 weeks, which cannot be attributed to any other dental cause. Okay, so any tooth mobility which is happening more than 3 weeks, and that doesn't attribute to any dental or periodontal cause. Okay. Second one, any oral ulceration or a mass or a growth persisting more than 3 weeks. Doesn't have to be painful. Unexplained red or white patches that are painful, swollen, and bleeding. White patches which is not painful, swelling, or bleeding is not considered as urgent, but it is considered as prompt. Okay. Unexplained lower lip. Okay, now this is the one which actually unexplained numbness of the lower lip and chin, which I've already told you, which cannot be attributed to any other cause. Again, mandible, any carcinogenic growth on the mandible can cause this, which I've told you about. Okay, unexplained sore or painful throat for more than 3 weeks, oropharyngeal carcinomas present that. Unexplained one-sided pain on the head and neck area for more than 4 weeks. So any pain on the head and neck region, one-sided, unexplained, you can't see any other cause for more than 4 weeks, can be referred as urgently. Unexplained neck lump, which I've told you about. Previously diagnosed that the lump that is changed over the period of 6 months. Okay, so 3 to 6 weeks. So previously you would have said, that lump is nothing to do with any cancer, but now it has changed in size in the last 3 to 6 weeks. It has to be referred very, very urgently as well, because it can turn into that. So what are the prompt referrals? Okay, prompt referrals has to be done. We don't have, to be honest with you, we don't have in the RIGO, we don't have the prompt referral form as such. As the people, my colleagues in the UK will know, there's in the RIGO, there is nothing like prompt referral. There is only routine referral form and a urgent referral form so far. But the prompt referral form will be added very soon into the RIGO. That's what we've been told. What you can do is in the clinical notes, you can in the extra notes, you can say it is a prompt referral which needs to be seen within not 2 weeks time, but they have to be seen within 3 months time. Okay, so prompt referral. Well, obviously 3 months is too much, but yeah, they are. Oral submucous fibrosis, which is not very common in the UK, but definitely very, very, very common in India, but not as common in Kerala, because we don't do the betel nut chewing, and tobacco chewing is not as common as in the north part of India. Mucositis, lichen planus, chronic hypoplastic pseudomembranous candidiasis. This is the one which we were actually suspecting that erosive lichen planus with. Okay, so that's the pseudomembranous candidiasis. The presentation of pseudomembranous candidiasis is exactly like that way, the one which I showed you, the erosive lichen planus one. Okay, and white patches with no redness or ulceration. So that's what I told you. White patches with any redness, ulceration, pain, or bleeding has to be seen very, very urgently. But with white patches or red patches, which is red patches with no redness or ulceration, has to be seen promptly. Recent unilateral salivary gland swelling could be due to the salivary gland duct stones. So non-urgent, which you all know, mucosal polyps, lichenoid reactions, pyogenic granuloma, recurrent oral ulcerations, amalgam tattoos, and everything. Amalgam tattoos nowadays we don't even refer nowadays. So now comes to the how to refer thing. Now in India the scenario is completely different. because we don't have, unfortunately, we don't. I worked in India, so I know exactly how it works in India. I've seen 2 patients when I was working in Kannur as a neurosurgeon there. So I referred myself, so I know exactly how it is done. So it has to be done at I'm sure you guys know how to refer. I'm just telling you to do that in your own ways, because you need, if you don't have a system in place, please make a system in place to do find out or identify the the area where you can refer in your area, which is the most important area to be referred. Know a person who is there personally, if you have, because in India it's completely different, not in here. And so you need to personally refer the patient to the concerned person in your particular area. If that has to be gone even beyond that, like in regional cancer centers, you should know the contact numbers, everything in place. You should have a proper set protocol yourself to see how, because thank you. So you need to have a proper set protocol for yourself. You don't have to show anybody, but you should have a proper way to refer the patient. Now, when I used to work as a regular NHS dentist, I used to do this whatsoever. Even if I'm running 50 minutes late, I do the referral. If I see a patient and if I think it is a problematic lesion or something that has to be seen in 2 weeks' time, I do it then and there. Most of the people I know, I work with so many people, so most of them do in the end of the day, because we are, most of the time it's the time factor in NHS, working very busy practices here. So we tend to put it in the end of the day or in the afternoons, in the lunch break. What happens to this is actually few things. One, and most important thing, we forget. Okay, we do tend to forget. We all are human beings. We don't, and it's not our case, somebody else's thing. So you just don't have it in your mind as a priority. So you tend to forget it. So please, it's a very important thing not to forget. And also, what happens is, like especially in the UK, where we have address and everything on the system. So we tend to copy paste the same address in. Some address in the system. So what happens? What happened in the past is actually a lot of people has been referred, but that address was, the patient has moved from that old address. So which we didn't know. The patient didn't tell us. So we haven't updated that address in the system. So the patient. The letter from the hospital within that 2 weeks went to some wrong address. Patient didn't know. Obviously, where it goes, I don't have to tell you. So, and when the complaint comes back, the patient, the dentist said, "Yeah, I have already done it, but it went to somebody else." So that won't happen if you do it in front of the patient. So what I do normally is actually ask them, "This is your date of birth. This is your address. Is that right?" You just do that then and there in front of the patient. So there's no chance of forgetting. There's no delay for the patient. There's no thing that I usually ask the nurse to put out the referral. Yes, straight away. Brilliant, Sonia. Straight away do it, or ask your nurse to do it straight in front of you. Just don't go to the next patient unless you do this. Especially it's an urgent case. Okay, and also the patient is seeing you doing it. So this is how we do it in the thing. So it's there is an options that comes, whether it's an oral surgery, whether in 2 weeks referral, it already comes up in the Rego. So it's a very easy one actually. The last one is informing the patient. Actually, it's very important. It's but at the same time, it's very sensitive. You are not sure whether until the histopathology report comes and says it is SCC or whatever it is. But until then, you are not sure what it is. So you don't have to tell the C word, cancer word, or you don't have to tell the patient. But all you can say is like it is something suspicious, and the protocol is I need to refer the patient, first refer you to the hospital urgently. So they will contact you. Another thing which I always tell the patient also is in that 2 weeks time, if the patient is going away, we need to ask them as well, are you going away in this 2 weeks time? So you can ask all that if you're doing the referral in front of the patient. Sometimes the next day patient is going for a holiday for 2 weeks, they would have not known about the referral come through. So these are the things which you can always ask when you're doing this then and there. Whereas if you do it later in the lunch hour or the later stages, you don't have that kind of information to put it on. So it is always, there is actually a column when it comes. It will say, right, whether the patient is away these 2 weeks. So you can clearly say whether the patient is away or not. So just doing it as an urgent basis for the safer side. So that actually brings up the end of the procedure, end of the presentation. I hope you guys was not that boring. You can ask me any bombarding questions regarding this. I don't know how to unmute you guys. Thank you, Doctor. Very informative. Thank you, SN. Thank you, Samir. Hi, Samir. You there? My colleague. Anybody has got any questions? Hello.
Yes, doctor. We have
Manu. Hi, Manu. Hi, Archana. Hi. Hi, Arora. Thank you. Shafika. Hi, Shafika. You there? Roll number 1 of Yanapoya Dental College. My batchmate from Yanapoya, 1992. Sadia. Hi. Thank you. You're welcome. Hi. Hi, Sonia. Alicia. Hi, Alicia. Hi, and Sabil, one of my 1-year junior, very, very respected person. Samir, which can be sharp tooth. Mohammed Sharif. Hi, Sharif, 1-year junior to myself in Apaya. Very talented photographer. Samir, can sharp tooth cause cancer? Yes, obviously, if it is yeah, very good question. Sharp tooth, this is what I said. Tooth, if it is the protocol is you need to smoothen or remove the cause of causing the trauma, and you need to see the patient in 2 weeks time. And if it is still not resolved, you need to refer the patient urgently. It can cause, yes, definitely can cause if it is. Sometimes the trigger has already been done, and it can actually go on to become, yes, 2 weeks. Yes, 2 weeks referral. Yeah, if you see the patient in 2 weeks time, and if the ulcer is not healed, you need to refer the patient straight away within 2 weeks time into that urgent one. Yeah. Ashwin, thank you. Indeed, very informative. Thank you, Ashwin. Amit, hi, Rosha, advise post-cancer treatment. Any advice on post-cancer? Amit, I have not gone into that because it's not our, it is not what we do. Thank you. You're welcome, Samir. Yeah, it is not what we actually are to be concerned on. What we are concerned is to be referring, identifying it and referring. That's why I thought I don't want to go into the details of how do you do the oral cancer, how do you stage it, and there are lots. I can sit and talk to you ages in hours regarding the cancer treatment, which we don't have to know about all that. I can teach you in a different time, but it is nothing that we have to. But at this point of time, what hi, you're welcome. At this point of time, there's no need for us to know about all that, but I can tell you if you want. It's a bit boring as well, to be honest. So I thought I will make it a bit more interactive, a bit more interesting, with some stories in there, and make you more intelligent in the presentation, rather than just boring you with some lot of things that you don't have to be worried about. Anyway, Samir, we need more. Oh, thank you. Thank you. I will. Such a patient. This patient with multiple. Sorry, I couldn't read that. I don't know. Shyam, is there any
Yes.
chance that, yeah, can you talk to them or no?
Yeah, I can. To whom, sir? To
To
SN?
the
SN? Or
attendees? Yeah, so yeah, normal blood test was normal.
no?
I saw the, yeah,
Can you please the name? Username?
Sadia.
Sadia. Okay, let me try. Once again. Sadia. Is yes. Now I think Sadia can.
Hello, Sadia. Can you hear me? Or? Hello? No. Hello, Sadia. Hello.
Hello, Sadia.
Hello.
Hello. Sorry, doctor. There is no
Hello.
response.
Yeah. Yeah, it's okay. I didn't understand, Sadia. Sorry, I didn't understand your question. Actually, there was you were asking about blood tests, and I don't know what exactly the question was because this messages comes up, and within seconds it just goes away. So sorry about that. I couldn't read it. Not that very quick in reading the
So we
messages.
got one more question from SN. I think you can read it from chat box. It's there from SN. Username is SN.
Chat box. Okay. Oh. Oh yeah, you can actually. So there is a patient who had multiple ulcers on the dorsum of the tongue. Okay, right. This is the one with Sadia. Dorsum of the tongue, which was painful, and it healed by itself. Okay, multiple ulcers on the dorsum of the tongue was painful. Okay, but it was recurrent. Okay, history of medication, allergy, drug interaction, toothpaste. Okay, the question is like this, sir. There was a patient who had multiple ulcers on the dorsum of the tongue, which was painful, and it healed it by itself, but it was recurrent. History of medication, allergy, drug interaction, toothpaste, spicy food, and habits were eliminated. What syndromes does that point to, and what tests should be ordered specifically? Right, as normal blood tests. Okay, all the normal blood tests were normal. Okay, it's a very good question actually. Most of the time, the multiple ulcers are related to stress. Young patients, because as the age goes, as they become older, it actually tend to reduce it. And then you have the deficiency problems. Now, the deficiency problems, most common one is actually B complex deficiency, which you said you might have already done the blood test. There is a few other deficiencies which also cause, it's called the zinc deficiency. Actually, you have to specifically ask for the zinc test. And zinc is very important, vital in the blood, and sometimes the patient has got this sort of painful multiple ulcers, and it is recurrent, is very, very common of as aphthous, because anything that is painful, recurrent, and multiple ones are not cancer. You don't have to be worried about it, but you can refer the patient again to a more specialized area where they can do all the blood tests. The zinc is one of the most common actually, even though it was not initially found, but zinc has caught something. So if you've not done that, you can. So which you've already done, the other ones, all the medical history is done, drug interactions, and other drugs, sometimes nicorandril causes ulcerations like that. some antihypertensives does it. These sort of things, medications, you already eliminated all that. Drug interaction, toothpaste and spicy and all these things. But most commonly it could be stress or zinc. What I could do is actually, what I think is actually, it could be either of those two. What else? Yeah. Doctor, I work in East London and mostly do bite wing and PA. We don't take OPG. So isn't it unfair to erase the dentist and hygienist? Yes. Examples in the scenario 1 and 2. I would have missed those scenarios. Thank you. Right. Ascent, it's a very, very valid point you said there. Actually, most of the dentists, we don't have OPG in our practices. But having said that, we have access to OPG outside in the hospitals. It is free in the hospitals. If you refer the patient for an OPG, it is free in Ashford area, where in the Kent area where we work. I'm sure it will be in your area as well. If you refer the patient to the hospital for an OPG, the patient can have it done. If not, if you are still not having that sort of service in your place, I would tell the patient the importance of the OPG, for having the OPG, and I can even refer to the patient privately to get an OPG done privately and see it, to refer it. I know it is very unfair to erase the dentist and hygienist. Yes, definitely. I am on your side. I definitely wouldn't like to do that myself, but that's what the law says. Because if you are not done the proper way of the referral, the investigations, you are not fit to, that's what they say, fit to be a dentist or hygienist. So that's what they say. Unfortunately, that is a situation. But you should do the investigation, even if it is not there in your hands. You have to refer the patient. And if you're still not happy about it, just refer the patient with the PA or whatever you have through the Rego, and they will then do the OPG and take it from there. So that's what you should do. If you're in doubt, just refer.
Sir, we have one more question from Dr. Shahjahan. Any blood examinations for suspected cases?
Any blood, sorry?
Any blood examinations for suspected cases?
There is no, well, there is tumor markers and all that, but that is all, highly specialized areas where they can do all there is no blood test that will tell you the patient has got oral cancer. No, unfortunately not yet. I wish we had. Not that I know of. I don't know whether the latest definition, the things have changed. I don't know. I can ask my very, very good colleague of mine, Jaya. Jaya, do you know anything about? She's very, very informative, and she works in the hospital community setup as well. So, Jaya, do you have anything regarding that? Pinch. Okay, that's your certificate. Brilliant. Okay. Marvelous job, Shyam. I'm really impressed with you. So, sorry, coming back to the question, there is no blood test as such. There is tumor markers, which you can find out whether this patient is actually more prone for a particular cancer. There is, but that's all very highly specialized things, which is only done in the hospitals and cancer centers and everything, but which is not. Let me just go back to the chats. My thesis for the same markers and beta. Yeah, okay, beta 2 microglobulin and CRP. Yes, they are all very high specialized things. So you can tell whether it is common. It's a common thing that can be done in the dental setup, or is there any particular blood test we can tell whether the patient is actually having oral cancer. Yes, and thank you for taking time out during the webinar. It's absolutely fine. It's actually better to do something like this rather than sitting at home and doing nothing. So it is my pleasure, as well as it's nice of for you all of you to come and do spend your time, valuable time with me. Thank you, not for me.
Thank you, sir. Sir, I request our
Thank you.
WDC
Oh, Manu.
representative.
Hello, Manu. My friend. Sorry.
I request our WDC representative, Dr. Rosemary, to share a few words.
Hello,
Dr.
hi
Ros-
sir.
Hello.
Hi sir.
Hello.
Sir,
Hello.
thanks Ethan, Dr. Roshith Valiyamannil sir. We are glad that you are enlightened us on the topic. It was profoundly informative. We could now take back with us a bunch of points and implement it in our daily practices, sir. We really appreciate your willingness to keep aside a part of your valuable time to share your knowledge with us. Once again, thanking you from the bottom of my heart on the behalf of Idea Ernad. Sir, stay safe from pandemic, sir.
Thank you. Pleasure is mine, actually. Just thanks to my roommate, Shah Jahan PA, my BDS roommate and very close friend of mine who works in, Thrissur area. So thank you again. Thank you, all of you. Thank
Yes,
you,
yes.
first of all, Dr. Mohsin and Shyam for all your hard work. And thank you, and all of you who has come.
So I think Dr. Joy Thomas sir is there. I think Dr. Joy Thomas Chirmal is there, sir. Our co-founder of
Dr.
Idea Ernad.
Yeah.
And also without Dr. Mohsin, we won't, without this happen, sir. Sir, Mohsin sir is a great
Exactly.
appreciation for sir.
Mohsin actually approached me initially to do this. That's why first thanks to him. And yeah.
Exactly,
And,
sir. And also
thank you,
our
Dr. Joy Thomas,
president.
for your, sorry, go
And
on,
also
sorry.
the president of our ITRNA, Dr. Bilal, Dr. Balkrishnan sir, and Honorable Secretary, Dr. Sanat Babu sir, and the man who behind the webinar, Dr. Shyam Shankar. Without you, it won't also happen, sir. Such a great coordination.
It is. Unfortunately, unfortunately, it is the technical things which is it didn't work on the Facebook, but otherwise, what a hard work, man. Thank you so much.
Exactly, sir. And also
again,
thanking
for
every member.
my batchmate Shahul.
Yes, sir.
Thank you. Hi, Shahul. Thank you so much for the message. Sorry, go on.
Okay, thank you every member that who joined us with us making this webinar. Such a section is meaningful from who all are. Thank you so much.
All right, thank you.
Thank you.
Bye-bye.
Thank you. Thank you so much. Thank you.
Sir,
Thank you,
Roshith,
Sam.
sir.
Thank you.
Sir,
Yeah,
Dr. Joy Thomas is,
yeah.
I promoted him as panelist. He can talk.
Hello, Joy sir.
Okay. Hello, sir.
Oh, hi. Thank you very much for this. An excellent session.
Thank you, sir. Thank you. You're welcome.
In fact, I had some, yeah, very much. Some connection problem in the beginning. I don't know, there's net issue was there. So I called Sam and he made it up. Thank you so much.
Thank you for coming, sir. I hope
definitely, yes. Even Mohsin sent a voicemail to me in the morning. Please be there. I was from 3:50 onwards, but some connection problem was. Anyway.
Oh yeah, there was some problem. Thank you.
Wish you the best, only the best in life. So wishing you to meet you
Thank you,
again.
sir. Thank you.
Thank you.
Thank you, sir. Thank you.
Okay.
Thank you.
Okay.
Bye.
Bye.
Yeah.